Welcome everybody, and thank you very much for attending this webinar. Although Alison and I are presenting, the content today has been informed by many dietitians working in the field, as well as the published literature. I just want to thank all the people who've taken time to speak to both me and Alison and send through insightful information about their practical experience. It's been really helpful in developing this content. I'd also like to thank our hosts, Nestlé, and also the BDA, who are supporting this webinar. The webinar will be recorded and will be available on the BDA website for members and also on the Nestlé Education Hub in the next few days. Alison and I wish to share with you our declaration, and we also wanted to reiterate that the educational content of the webinar has been wholly developed by ourselves, and it's not been influenced in any way by Nestlé Health Science. And the webinar platform, the launch, the marketing of the event have all been provided by Nestlé Health Science. The webinar is divided into 3 sections. First of all, I'll draw upon the published literature and the available evidence and focus particularly on issues related to nutrition and the COVID-19 infection. This will be followed by Alison, who will talk more about the pathways of care, the resources available, and all nutritional supplement use in the community. And then we'll finish with a question and answer. We've invited an audience of healthcare professionals. These will be largely dietitians, but we also welcome other carers, other carers, nurses, doctors, and other allied health professionals. And so we've tried to tailor our information to this wider audience. So I wanted to start with some feedback from ICU dietitians, and this is largely from the team at St Guy's and St Thomas's in London. So many patients have long ICU stays and consequently long periods of mechanical ventilation, and that leads to considerable weakness and muscle wasting. There's also the severe inflammatory period, which leads to ongoing catabolism, and we're not sure how long that will last. There is hyperpyrexia in the acute phase of the infection, and that leads to hypermetabolism and additional fluid losses. So all these factors combined mean the patient group is difficult to manage in terms of nutritional feeding, and there are frequent feed interruptions. And that's partly because of the severity of the illness and also the method of proning in the nursing of these patients. And so that means patients are frequently behind in their nutritional targets. On top of this, it's been observed that blood glucose and insulin management is more difficult in patients with diabetes, and we're not really sure how long that difficulty lasts and whether it resolves fairly quickly once patients moved into the ward and into the community, or whether that is a problem that will hang around for longer. One of the questions I've been asked is how long this catabolism lasts. The simple answer is we don't know, but I thought it was worth presenting some data from my team. This was data collected by Lisa Wondrag during her PhD, and we looked at a group of moderately prolonged stay patients from ICU and looked at their nitrogen and energy and protein balance. And you can see in this cohort the significant negative nitrogen balance in many patients right up to day 14, and similarly with energy and protein. So even as long as 2 weeks in some patients, there's negative nitrogen balance and catabolism. And so we're not really sure, and our overall conclusion was that there was so much variability between individuals, it was impossible to give a time-based assumption that there is a point where the metabolism will tip into anabolism. And moving on to feedback from the hospital wards, what was really interesting to hear that the patient characteristics in the hospital wards are quite different to what is normally seen in care of the elderly wards, who are usually very frail, with chronic long-term conditions and in chronic decline. And it's been observed that patients now are frequently well and entirely independent prior to admission, and very few are underweight. So it's quite a different cohort of patients to look after. Screening is particularly difficult at the moment because of infection control measures, and so patients are not necessarily being categorised as nutritional risk, and also because they're quite well nourished when they come in, some of the screening tools may not pick them up. Because of increased oxygen requirements for people who are very breathless, there are difficulties in coordinating chewing, swallowing and breathing. And that's meant that many patients prefer soft and liquid foods for their meals and snacks. And then with the significant loss of muscle mass, strength and function, that's related to ICU-acquired weakness that is clearly going to be seen due to the long ICU stays. And so we know exercise is going to be an important part of recovery. But in order to do the exercise, it's important that people are adequately nourished. Another point that's been raised is that there's a difficulty in identifying patients who need extra help on the wards, and that's because there are different staff to usual. Also, there's no visitors, so it's not always easy to identify which patients are not eating very well, and also who needs help with meals. And there are also visitors don't bring in extra treats or explain patient preferences, and there are less staff around to prompt at meal times. So there are many points in the system that have changed radically during this COVID pandemic. Dysphagia is another aspect that's been difficult to identify due to the coughing symptom related to the virus. So it makes it much harder to notice the symptoms of dysphagia. And finally, dehydration may be a significant issue because wards are quite hot, doors are closed because of infection control measures, and that reduces air circulation. Use of oxygen increases the dryness in the throat, and that there are less staff around to prompt drinking. So dehydration may be a major problem for some people. This again is from Guy's and St Thomas's Hospital. This is the dietetic team looking after COVID patients, and it's led by David Gray. And they did a fantastic audit of food consumption on the ward. So this is a real team effort, and any dietitian will know that this is quite a hard, time-consuming thing to do. So I really congratulate them in collecting this really useful data. And so what they observed, they measured how much of over 300 meals were eaten. And the amount eaten at 80% of those meals was less than 400 calories. And ideally, we'd be looking for people to eat more like 800 calories at a meal. Only 6% of the meals eaten met that energy target, and only 26% of the meals eaten met protein targets, which would be about 25 grams of protein. And those targets are taken from the BDA, Nutrition and Hydration Digest, to the nutritionally vulnerable. And you can see in the bar charts the data broken down by gender and age group. And finally, some feedback about the discharge process. This is happening very quickly. So there's not always time to plan and provide food first advice in time for home. Patients may be discharged before their appetite's recovered, and we've got very little information on how long this appetite suppression may last. But we know that normal body weight can quickly become underweight, and that will store up problems for the future. And because patients may look better nourished initially, there might be a failure to pick up these problems moving into the community and lead to a deterioration. It's worth noting that the amount of information coming out with patients when they're discharged from hospital is very variable, and that's something worth checking for community staff so they know what patients will have when they leave hospital. Some may have written information, some may have prescriptions of supplements, and in other locations nothing is being given out due to infection control measures. I wanted to highlight the use of the Patient Association Nutrition Checklist. This doesn't require weighing, so it may be easier to use, and it's been validated, so it's a really useful resource to use and promote the use of, and it can be done by the patient themselves to self-identify problems. And finally, we know finding information can be difficult, and that's one of the reasons why we wanted to do this webinar, was to try and bring together some of the useful resources and information for staff working in the community. And so Alison's going to talk a bit more about this in her section, and the BDA are collating a library of resources that you can all use. This feedback from the acute sector really helps us build a picture of who our patients are going to see in the community. It's worth reflecting that most of the data we have is from hospitalised patients and not those in the community with a milder response to the disease. And so these patients seem to be older people, particularly men. They have multiple morbidities, including diabetes, hypertension and obesity. But it struck me that surely the people most at risk are the frail population, who are the very old, have frailty, have multiple morbidities, and are quite dependent. But these are not the patients that are being admitted to hospital. It may be their choice to remain at home and to be cared for at home, and we've sadly heard of really high death rates in care homes, and it may be this patient group are particularly succumbing to this infection. So the patients who are going to need nutritional care in the community are those already at risk of malnutrition and who are at risk of getting the COVID-19 infection. And in addition, there are going to be those now at risk of malnutrition having had the infection. I wanted to think about the numbers of patients that are going to be out there. And clearly most of people with COVID infection are in the community. Anybody can get it. But we know that the older multiple morbidity are at greater risk. And these are the patients that are being admitted to hospital. And it seems, so this is data from China, between 11 and 18% of people over 60 are admitted, who get the infection, are admitted to hospital. And those higher proportions are the over 80s. I was then interested to try and get a feel for how many of these people are being admitted to ICU. And so using Cabinet Office briefing room data that was presented in the Health Service Journal, and this is data just for London, it's appeared about 20% of those hospitalised will be admitted to ICU. The Intensive Care National Audit and Research Centre is producing really useful data to describe the patients who are in ICU, and this is produced weekly. So you can see this data shows the survivors have a median length of stay of 5 days, between 2 and 9. It's worth noting here that this data is biased towards shorter stay patients because the longer stay patients are still in ICU and their data isn't fully processed. And then looking at who gets advanced respiratory support, you can see the majority of patients are receiving that, and that means that they will be intubated with the corresponding consequences of that procedure. So the COVID-19 infection brings a new set of nutritional problems that are related to the symptoms. So we're all familiar with these symptoms of pyrexia, coughing and fatigue, which are the commonest symptoms, but there's also a range of other symptoms: myalgia, the loss of appetite linked to changes in taste and smell, and breathlessness, headache, diarrhea, coughing blood, and also inflammation of lung tissue. So all those have occurred with this infection, and you can see that many of those are going to influence nutritional intake or affect nutritional status. On top of that, patients in ICU will suffer other symptoms related to critical illness and care in that setting. So there's the well-recognised ICU-acquired weakness, which is related to the catabolic state and lean tissue loss. There's also dysphagia-related problems due to intubation. There's post-traumatic stress disorder, and then a variety of other symptoms that are related to nutrition in terms of appetite, taste changes, bowel problems, low energy and low weight loss. And we've described these in more detail in another study, which I'll show in the next slide. This is a study carried out by Louise Olbrich at Yeovil Hospital, and she looked at nutrition-related symptoms that are common post-ICU, so in ICU survivors. And you can see that there's a huge range of symptoms that are linked to nutrition or could affect nutritional status or intake. And many of these are severe and many persist in the long term. So you're building a picture here of patients who potentially have a considerable number of problems relating to nutrition being discharged into the community. Undernutrition. This is a recent systematic review looking at rates of malnutrition in the older population. So we have a large population of older adults being discharged from hospital into the community at varying risks of undernutrition, many of which may not be identified. We also know that undernutrition compromises immune response. So failure to maintain or improve nutritional status in patients will leave them at further risk of infectious or other complications further down the line. My colleague Anna Julian, who was a PhD student, and she looked at a cohort of older patients being discharged from hospital and followed them up through their recovery in the community. And this data showed that even people at low risk of malnutrition, deteriorated further in terms of their activities of daily living and their ability to perform those. And some of the symptoms or problems reported were problems with food preparation and problems with shopping in quite large proportions of these patients. So that clearly is going to lead to a greater risk of a poor intake. And the current problems of social isolation and food delivery issues further complicate matters at this time. Indeed, our data showed that. So these are people who provided diet diaries, and we were able to see how their food intake changed over the 12-month period. And you can see that although people's intake improved post-discharge, certainly many people still remained eating inadequate amounts of both energy and protein. And then looking at the systems of hospital discharge, these are often inadequate to successfully hand over nutritional care. So at the moment, screening is really difficult and maybe impossible during this COVID pandemic, so that exacerbates these difficulties. In our cohort of older people we followed up, we found 36% of people who should have been referred to dietitians in the hospital weren't, and the people who were not under dietitians had virtually no information provided at discharge about their nutritional care. And once in the community, it was really unlikely people would be identified and referred to dietitians. But those who were, interestingly, did much better than the people who did not receive dietetic input. So that's really encouraging to know. So this problem of the transfer of care from the acute to the community isn't a new thing. It's probably just going to be exacerbated in this current situation. So there's data from BAPEN that has shown problems over the last couple of decades, and then there's also data coming out of Europe that show that other countries equally struggle with this. So it's a very difficult problem to tackle. So all this means we have a perfect storm of nutritional issues that could trigger a downward spiral of deterioration, resulting in future hospital admissions, ill health and frailty. In my last few slides, I just wanted to focus on some of the important nutrients to consider. So clearly protein is critical, particularly with the large amount of lean tissue loss that's going to occur for patients who have been in ICU. So these are the UK reference nutrient intake values. 0.8 is a more international value. And then the older people specific values have been developed by a European consensus group. So there's a kind of broad consensus now that older people do need more protein than a healthy young population. And so I've translated those figures into grams of protein per day for a 60 kilo person. So the figures at the lower end of the spectrum are achievable if somebody has a reasonable intake, but many of these patients may not have a good intake. And then the amounts of protein at the upper end of the spectrum are really quite challenging to achieve, particularly with a poor intake. And so they're going to take quite a lot of careful dietary planning and are likely to need the expertise of dietitians. I also wanted to consider HMB, or hydroxymethyl butyrate. There's been some discussion about this in the literature and in the profession. So this data on the left is the most recent meta-analysis on older adults. Not all of these are frail older adults, it's just older adults generally. And this data shows that supplementing HMB can improve muscle mass without changing fat mass, which of course would be what you wanted. But the problem with the data is that it's not showing a consistent effect for functional measures. And arguably, it's those functional performance measures that are more important for people's health and well-being. And that's similar to what we found in a study I was involved in, which is the study described on the right. And we compared two groups of sarcopenic older people who were both supplemented with energy and protein, but only one had HMB included. And we found no difference between the two groups, apart from a certain specific subgroup. So although this is a really promising supplement, I don't think the evidence is really strong enough yet to make broad recommendations. We know vitamin D is associated with an increased risk of frailty, which is shown here in this forest plot. And there's also evidence that there's a modest effect of vitamin D supplementation on muscle strength. So I think vitamin D is really important to consider, and also during this time of social distancing and isolation, it may mean because people are staying indoors far more, that there is a higher risk of low vitamin D status, particularly in the patient group that we're thinking about. Public Health England has recognised this, and so their advice during lockdown is to consider taking a 10 microgram vitamin D per day supplement. And I think there's really strong evidence to suggest that's a sensible thing to encourage. This study looked at the quality of diet, so not just protein and energy, but also the overall quality of the diet is important. So we know poor quality diets, so low in micronutrients, lead to a higher likelihood of developing frailty in the future. And we know that many micronutrients are really important in terms of immune function. So vitamins A, C, D, E, B vitamins, also iron, selenium and zinc are crucial. So it's really important to encourage, where there is a deficiency suspected, supplementation of a daily allowance of macronutrients. Megadoses are not required. Alternatively, trying to improve people's food intake to ensure appropriate micronutrient intake. And finally, exercise. We know this is vital to combine with nutritional supplementation to optimize health. So exercise is crucial for mental and physical well-being for anybody. And there's growing evidence that there are significant benefits of combining exercise in rehabilitation of patients after illnesses. So this study I'm showing you here was for older adults with sarcopenia and frailty, and they were supplemented with protein and energy alongside exercise therapy, and that showed significant benefits for muscle mass, muscle strength, and also functional abilities. So I think for considering our practice in the community, it'll be important to collaborate with physiotherapy colleagues to ensure at-risk patients get the appropriate advice for exercise and, if necessary, appropriate physiotherapy alongside the nutritional therapy. I've hopefully shown that there's going to be a range of patients who will need treatment in the community who are going to be at quite vastly different levels of nutritional risk. So there may well be a need to try and configure some sort of triage system to help identify those most at risk and ensure they are the ones prioritised for dietetic intervention. And clearly the most at risk are likely to be those discharged from extended stays in ICU. But all patients from hospital are likely to be at risk of deterioration and poor recovery unless they have adequate nutrition. So it's ensuring everybody has that information. But the difficulty is that not everybody is going to be easily identified at risk, and because screening may not have occurred, and also there's modified discharge systems. It's worth mentioning that obesity can mask sarcopenia, the loss of muscle, and so patients may not look obviously malnourished, so they can be more difficult to identify. And we know that exercise and optimal nutrition are going to be central in preventing further deterioration, future frailty and readmission to hospital. So there is a huge workload out there to identify and treat and monitor these patients who are at risk in the community. The other thing to mention is not everybody will be at risk of malnutrition, and because this patient cohort also have other comorbidities, those comorbidities also need to be managed well. And we have very little information about how long appetite loss lasts, and things like how glycemic control is affected in the longer term. Also, as I've mentioned with obesity, people who are very overweight may lose weight, which might be helpful in managing their conditions, but in this acute situation is not a great way to manage weight loss and will mask underlying muscle loss. So I think my last plea was that we've found very little data, or perhaps no data, on recovery of COVID in the community with a focus on nutrition. And so if you are developing new systems and you can build in some sort of evaluation and data collection into that, it would be really helpful to the whole community. And certainly UK dietitians, if you need help with analysis or other advice, do contact the BDA.
Hello, I'm taking over from Mary now. It's Alison Smith. I'm prescribing support dietitian in Hertfordshire, and I'm also chair of the Older People Specialist Group of the British Dietetic Association. I'm just going to cover a few different things from Mary. My focus is absolutely going to be on older people because that's my area of expertise, and I'm going to have a look at what the requirements are of community staff, talking about pathways of care from hospital to home, looking at oral nutritional supplement use in the community, talking a bit about dietary counselling and food fortification, and about the available resources. It's very much going to be a combination of lots of different things that I'm talking about, and I'm not going to focus on obesity or diabetes because there are a lot of people far better qualified than I am to focus on those. So it's basically going to be looking at the whole gamut, and it's also thinking about the people who haven't been on ITU who may well still need nutrition support. So thinking about community staff, I'm looking at NHS England. I appreciate there will be people on the call who are from the other home countries, and I apologise for not including data from Scotland, Ireland, Northern Ireland and Wales, but the NHS England data is the one that I have most access to, and what it's advising is what the priorities are for community health services. They're fairly obvious. It's supporting home discharge today of patients from acute and community beds and ensuring that patients cared for at home receive urgent care when they need it. Using digital technology, obviously as we all are at the moment, but continuing to provide advice and support to patients using that means wherever possible, prioritising support for high-risk individuals, those who are advised to self-isolate for 12 weeks in particular. And one of the most important things, I think, is the principle of mutual aid with health and social care partners. So from my perspective, working in older people's care in the community, particularly focus on older people's care homes where, and care agencies as well, where people are going to be cared for in their own homes. One of the things that the BDA is working on is supporting Public Health England on the food packs for the shielded population, and also supporting volunteer agencies who may be helping to provide food for people who are vulnerable but not necessarily shielded, but may well be self-isolating for 12 weeks. So thinking about community staff, although I know there are other professions besides dietitians on the call, as a dietitian myself, I did want to just focus on what NHS England specifically is saying about dietetic services. We're all, I think, very aware that a lot of dietitians working in the community have been seconded into acute environments, have been redeployed into acute environments. However, I think it's quite important just to be aware that community dietetic services, NHS England advises that we do still focus on admission avoidance and supporting discharge, and that we prioritise services to manage malnutrition and enteral feeding. And obviously, as we've already heard from Mary, one of the things that we're absolutely going to see is a lot of people coming out of hospital with malnutrition. But even those who haven't been into hospital may well have malnutrition as well. So we need to remember that in terms of the service that's available in the community. In terms of any other healthcare professionals in the community, it's really important to continue to follow your local area NHS, and that's your clinical commissioning group or your local health board if you're in the other home countries, the guidance about identifying and treating malnutrition, because there will be guidance in almost every area, so make sure you're familiar with that because it is so incredibly important. So moving on, thinking about malnutrition and frailty just in general, as Mary's already said, malnutrition is a particular problem in this country anyway. It's a particular problem for older people, and the older you are, the greater your risk of both malnutrition and frailty. It's something that we're really trying as dietitians to get involved in nationally, and to support the frailty agenda that's continuing in clinical commissioning groups and in primary care, but also in acute care as well. Obviously, we've already heard malnutrition, it reduces resistance to infection, it increases likelihood of acute admission, it increases length of stay, it reduces quality of life. And generally speaking, malnutrition and frailty will often coexist together. The little diagram that you can see on the slide is actually some guidance I produced for my own clinical commissioning group, just to try and make the point that malnutrition, or just nutrition in general, is a really important thing to remember when it comes to frailty. And it was felt by the Older People Specialist Group that we ought to produce this, we ought to put it on the BDA website so that everybody else could access it. And it's certainly been something I know some other areas have found quite useful. So if you're a dietitian, this is accessible. If you're not, if you can contact me, I will let you have this, no problem whatsoever. So moving on to thinking about pathways of care from hospital to home, again following what Mary said, we know that the information following patients may not be particularly good when it comes to nutrition. So it's quite important to think about what the information is that currently or previously would come out within discharge summaries. How are patients then usually referred for ongoing support regarding nutrition? What are the pathways that normally exist, and do they still exist now during the period when COVID is such a problem? Have all of those pathways changed in light of COVID? Are there staff who've been redeployed into the acute setting who may not know about what the pathways are? Is there communication going backwards and forwards? So as you can see, this is very much about the questions that perhaps we as clinicians, whether we're dietitians or whether we're not, it's the questions that we probably need to be asking. The other thing to, of course, be really aware about, and as Mary was saying, rehabilitation following ITU stay or even just following hospital admission may be quite an extended period. Therefore, one of the things that can be incredibly important to know about is what post-COVID rehabilitation options there are within your own area. What are the nutrition support options that are available within those locations? Do you have access to food in the same way as in hospitals? Do you have access to food more in the way we would have in the community? What access do you have to prescribed oral nutritional supplements? Really making sure that you're aware what the options are for these areas, because it is quite important to be clear on what might be available in your area. Again, as Mary was saying, any written information about nutrition support, about food aspects of meeting people's nutritional needs, has anything been provided either physically or electronically at the point of discharge? As we heard earlier, the likelihood is it may not have done. In my own area, this we've explored with the dietitians in the acute setting, and for infection control reasons, there will be nothing physical going out of hospital with the patient, which obviously means that we need to ensure there is a system in place to send that information, probably electronically if that's possible, to the patient or their carers post-discharge. So it's working out, is there a system, is there a way in which we might be able to do that? It's also about thinking about what third sector support there might be available in your area for post-discharge support. And this is a really important thing. I know in some areas there are hotels being repurposed as almost step-down beds from hospital, and there are caterers who would normally be working in the hospitality industry who may well have volunteered to provide catering into those settings. And there is some really great resources that are produced by Oak House Kitchen and by dietitian Helen Simpson, basically talking about how chefs can actually upskill if this is not their normal area of work, so that they can make sure that people get the nutrition that they actually need. Because as we know, food provision for hospitality is going to be very different from food provision for people who are nutritionally vulnerable. The other thing that's worth thinking about, particularly if there's been much work in your local area regarding the frailty agenda, is actually could any of the local pathways regarding management of frailty be useful to consider at this point? Particularly, I would say, the relationship between nutrition and exercise, because certainly I know within my own clinical commissioning group we're looking at the importance of exercise, but making sure that we're linking it with nutrition, and as we've already heard, that is incredibly important. Thinking about oral nutritional supplement use in the community, we know that ESPN have recently published the expert statements and practical guidance for nutritional management of individuals with COVID infection, which is incredibly useful. And this recognises the role of dietary counselling and food fortification as an essential part of treatment. It also obviously advises use of all nutritional supplements where the food-based approach is not sufficient to increase dietary intake and reach nutritional goals. This is under Statement 5, so it's really easy to find within this document. One of the other things that can be quite challenging, however, is one of the other pieces of advice within Statement 5, which is monthly review of efficacy and expected benefit if all nutritional supplements are prescribed. Now, this is quite an ask normally to do this review monthly, but I would suspect even more so at the moment. So even as a dietitian or as another healthcare professional requesting all nutritional supplement prescription, it is important to think about how, when and by whom review of the use of oral nutritional supplements is going to be completed. What is practical, what is reasonable, because obviously these prescriptions need not to just be open-ended, because they do need to be connected with some outcomes so you can see whether they're being effective or not. So it's an essential part of treatment to factor that in when you're making these decisions. We also know that 29% of patients may have dysphagia at the point of discharge from acute care. Therefore, we need to consider modified texture food or modified texture supplements, if appropriate, for this group of patients. Continuing to think about all nutritional supplement use in the community, we're looking at when it's appropriate to consider all nutritional supplement prescription, and obviously it's where it's clinically indicated, and you do need to think about what your local NHS guidance is regarding appropriate prescribing. The other thing to bear in mind is whether patients meet ACBS indications for the prescription of particular products. Now, I'll talk more about ACBS indications on the next slide, but one thing just to say at this point is that ACBS indications don't include any issues relating to food access. So if that's the main problem for a particular patient, that's a social care issue. So that does need to be addressed in a different way rather than through prescribing of something. This is the time to definitely make sure you know what your local clinical commissioning group or health board or nutritional supplement prescribing guidance says, particularly if you think there might need to be some temporary changes to what is advised based on the needs of patients on discharge from hospital or just in the community generally following COVID infection. The starting point for this is, does your local organisation have a prescribing support dietitian working as part of it in your clinical commissioning group or health board? If so, that's where to start. If not, then it would be talking with the medicines optimisation team within those organisations. The reason for this is because as clinicians we often think if we request a particular product to be prescribed that that's exactly what will happen. The reality is it isn't quite that simple. There will be systems in place within GP notes to suggest alternative products if the ones that we've requested perhaps aren't the most cost effective. So if you're thinking that despite that it may be appropriate that these are being used, that does need to be discussed and agreed up front with these organisations so that your patient gets what you think they need, because otherwise that can just result in delays to the patient actually getting what they need. So have the conversations up front. The other thing to think about is how and by whom the person's progress and the continued need for oral nutritional supplements is going to be reviewed. We often will pass on the review of these patients to their GPs if they're not continually being seen by a dietitian, for example. But at the moment, just like everywhere else in the NHS, for GP practices and community pharmacies, they are under a huge amount of pressure. So it's thinking very pragmatically about, is this the right source of the review? Would it be better coming from someone else, for example, from community dietitians who are working in this area? Or even, is there a need to talk with primary care pharmacists within GP practices to consider what they might be able to do to support these patients and to review their progress? Because ultimately we're looking to make sure our patients are actually taking the product as prescribed, as you've advised, because if they're not, we need to think differently about what they can have in order for them to be nutritionally benefited by these products, because obviously something that somebody doesn't take doesn't have any benefit nutritionally. So as chair of ACBS, the Advisory Committee on Borderline Substances, it is important to be aware of what those ACBS indications are for individual products. This may feel a little bit like teaching grandmother to suck eggs, for which I apologise, but actually it is quite important to know about this, whether you're a prescriber or whether you're requesting a prescription. The only definitive list of ACBS indications is the drug tariff. So that is where to go to find out what the ACBS indications actually are. It's a free to access website, so basically just Google drug tariff and you'll find it nice and easily. But pull the document up as a PDF, because then you can search it and then you can find the product that you're looking for. But a word of advice, don't assume that you know what the ACBS indication is, because the likelihood is you could be wrong. As dietitians, we've long been told that it's a standard 9 indications for each product, and that isn't actually the case. So please do check and make sure that you can evidence how the person meets the criteria for that specific product that you are requesting. The other thing just to be aware about is that in the future, ACBS indications are going to be changing. We're working on this in terms of standardization and simplifying of what the indications actually are, so do keep checking the drug tariff. It's updated every single month, so as things change it will go on there, so make sure you know what you're talking about. As we know, dietary counselling and food fortification are a central part of treatment of malnutrition and treatment post-COVID infection as well. And they're also a key role for dietitians working in the community, but for all other community staff as well. Particularly as dietitians both can and do support and train other staff to provide this sort of support for patients as well. So if you're thinking perhaps some more training at this point would be useful, it is possible that might be available, but find out from your local area. The thing is that dietary counselling and food fortification is supported by evidence. It's supported by the NICE clinical guideline from 2006, which obviously was updated a couple of years ago, and it's also supported by NICE Quality Standard 24. It's saying that we need to be making sure that whatever nutrition support we offer to people, it contains a range of different nutrients, the things that we would find in a nutritionally complete diet. And as Mary said earlier, that may mean for some people in terms of micronutrients, the vitamins and minerals, that actually taking a supplement may be the best option, either for a short period or for a longer period. One of the things to bear in mind, though, is that a multivitamin and mineral supplement that you can buy from a pharmacy or from a supermarket will usually be a very cost-effective way of providing those vitamins and minerals, and odd as it may seem, will be about 5 times cheaper than the NHS is going to pay for the same product. So asking people to purchase that for themselves is not necessarily an unreasonable thing to do, when you bear in mind that one a day purchased from a supermarket will probably cost less than £15 a year. So bear that in mind. So continuing to think about dietary counselling and food fortification, we know that this is an incredibly important part of treatment of malnutrition at any time, and particularly now, as seen from the ESPEN guidance. Whether or not all nutritional supplements are prescribed, it remains an essential cornerstone of our treatment of people in this situation. Generally speaking, when we think about food fortification, the tendency may have been in the past to really focus on increasing energy intake in food using high fat and high sugar ingredients rather than on increasing the intake of all nutrients. Now, as we've already seen, what we really need to be trying to do is to increase a range of different nutrients in the diet, not just energy, not just calories. So really, if we can try to focus more on nutrient-dense foods, which provide a range of nutrients, including protein and vitamins and minerals, as well as energy, that's likely to be better, and it's going to fit into the evidence base more as well. So you can see from the list of ingredients that I've given here, all of these are high in protein, they have a reasonable energy intake, and they also have a reasonable vitamin and mineral content as well. So they do provide a nutrient-dense addition to food rather than just an energy-dense. The other really good thing with all of these is that they can be added to foods that are not requiring much in the way of chewing, so soft or even puree or sort of liquidy texture foods. And particularly we know for patients coming out of hospital post COVID, what they may be fancying are things like soup and yogurt, very easy to eat foods, and actually fortifying those is tremendously important, and all of these ingredients can lend themselves to that sort of thing, which is incredibly important. The other thing we're thinking about dietary counselling is we're thinking about how people eat. What can we encourage that will help people to eat as much as they're able to without having to go back, without being able to go back to eating sort of 3 meals a day. So thinking about eating little and often, small amounts. What are the tempting foods and fluids? What are the things that people like? What are their personal preferences? Because obviously we know ordinarily if we're feeling well, if somebody gives us a food that we're not particularly keen on, we'll probably eat it. But actually if we're not feeling well, the chances are we probably won't. So it's important to really maximise what people really prefer at this point. We also need to think about taste changes in light of COVID as well. What are the things that we could do that would help? Is it that somebody simply can't taste food at all? Therefore, stronger flavours might be what's needed at this time just to really tempt people to eat something. The other thing to think about is what are people's food memories? What are the foods that they associate with comfort and basically feeling well? As a child, there were always foods for, I think, all of us that you associate with not being well, and you had those foods and they helped you feel better. So actually, would those be foods that people might fancy at this time? Now, ordinarily, when I'm talking about dietary counselling, I'll talk a lot about eating with others, because we know that can increase appetite, it can increase people's desire to eat. And we know that at the moment, this is a really challenging time. And particularly if somebody's coming out of hospital, they may well be in self-isolation. So we need to be aware of the psychological impact of being separated from others when you're trying to eat and you're not feeling well, and the impact that that is going to have on people's ability to meet their needs. Moving on to thinking about what resources are available, as Mary said earlier, there are a lot, and there's a lot of stuff that's available on the British Dietetic Association website. Now, I appreciate for those who are non-dietitians on this webinar that these are resources that are going to be locked to dietitians, but if you work with a dietitian, the likelihood is they will be able to access them, so you would still be able to see them. There are some really helpful recommendations for community action by dietitians working with older and more vulnerable people in the community that you can see. There is also some really helpful information talking about eating and drinking at end of life. I know this is not necessarily what we're talking about at the moment, but it's worth just knowing that's there. The other thing that's fairly new is some top tips for appropriate prescribing of oral nutritional supplements and enteral feeds, tube feeding, in the community for both adults and paediatrics, which has been developed by the Optimising Nutrition Prescribing Specialist Group, and all of these are available on the BDA website. Mary mentioned earlier the Patients Association Nutrition Checklist, and unsurprisingly, I'm a big fan of it as well. This is the website to go to, but again, if you just Google it, you will find it no problem at all. It's a validated tool, it requires no measurements, it can be formed remotely, so if you're working digitally, you can do it over the phone, and the second section of it has been adapted to take into account the problems that we're experiencing at the moment with COVID. You can see a picture of what it looks like. You can also see a picture of the nutrition wheel, which is a slightly more interactive version of the nutrition checklist, which has been developed by Wessex Academic Health Science Network. The other thing that's incredibly important, again, as Mary has said, is activity. It's the exercise side of things. Resistance exercise is known to be particularly beneficial, in addition to adequate protein intake, for people with sarcopenia. Chair-based exercise is also important and appropriate for people, even if they can't stand up. And one of the things I've thought was incredibly inspirational that I've seen over the last few days and last couple of weeks is the gentleman, Tom, who is actually doing the sponsored walk around his garden. Now, where I live in Bedfordshire, Tom lives about 5 miles away from me, which makes it particularly pertinent. But bear in mind, this gentleman is 99 years old and he is taking this exercise every single day. And so for his nutritional status, that is almost certainly going to be improving things. And of course, he's raised £28 million for the NHS, which is not a small feat. So the other resources that are available are ones that are more freely available, both for older adults and their carers. They also link to from the British Geriatric Society and from the Malnutrition Task Force website, which is fantastic. So we make sure we have the same consistent messages across various different websites. So you can see a selection of different things here. There's a really great resource that has been developed in Devon, looking at eating well with a respiratory disorder. The two lovely infographics in yellow are developed by the Older People Specialist group together with others, and we've also got some other resources that have been developed with different agencies that can just help people to understand how to meet their nutritional needs in these really trying times and how to maximise the food that they may have access to, whether they're in the shielded population, the vulnerable population, or they're able to go to the shops themselves, or whether somebody is buying for them. All of these supports may be helpful. So again, you have the website addresses there to be able to access these things. The last thing to say for me is just to make you aware of some resources that are in planning, but obviously for very obvious reasons are currently on hold. So there is some guidance planned that we're working with the British Dietetic Association and is supported by NHS England and Improvement on looking at bridging the gap between the Eat Well Guide, which is the guidance from Public Health England, talking about healthy eating for the whole population, but also it's the space between that and what we do to treat malnutrition. We know that for a lot of older people, even without COVID, there is a problem with malnutrition, and we know that it occurs. So what can we do to try and prevent it? So it's kind of that middle ground between healthy eating and treating malnutrition. We need something a bit more appropriate to prevent malnutrition. So that's something that is in planning. Unfortunately, COVID got in the way of us being able to take steps to advance that, but it will be something that we'll be looking at again once this is we're in a better position. The other thing that again COVID has put on hold for us is some guidance on nutrition for Care Quality Commission inspectors. This is led jointly by the British Dietetic Association and by the Care Quality Commission, and again this is something we will be able to pick up once we're out of this current situation. So the final points for me really are that community care both post-discharge is just as important as acute care, and it's going to take a lot longer. So we need to make sure that we're aware of this and that we're maximising the resources that can be available to patients and their carers out in the community, as well as what's happening within hospitals. Ask questions, find out the answers to those questions as much as you can before you take action, and work collaboratively. I particularly love this phrase, pinch with pride. This was coined, I believe, by Caroline Lecco from NHS England and Improvement. And it is about saying, we're going to use what you've already done because it's brilliant. So thank you so much. We're going to use it. We're not going to reinvent the wheel. And I think that's a really important thing to bear in mind at this time. It's also about utilising local support from the third sector and volunteer providers to help support vulnerable people. It's that sort of cross-sector working, making sure that we're engaging with them as well to enable them to work with us too. Consider repurposing any work that might already be done on the frailty agenda, because that might be quite useful now, thinking about sarcopenia. And do remember that food remains part of treatment, whatever other treatment is indicated. I included this little picture at the bottom because during COVID, this arrived in my post. It's from the BDA when we got our registration for this year. And I particularly love the fact that it starts, love food. And that really is where I want to finish. Thank you very much. It's from the BDA when we got our registration for this year. And I particularly love the fact that it starts, love
Remember, there's a
Thanks
slight
very
delay.
Oh,
Go ahead.
thank you very much, Mary and Alison, for your presentation. We're going to now walk into the Q&A session. And the first question is, are we concerned regarding too much protein, as some of these patients also have chronic conditions like diabetes and chronic kidney disease?
Shall I try and address that? We're talking about looking after patients with quite complicated needs when they have chronic kidney disease. So a dietitian does need to consider the protein level, and some of the recommendations made by the European Consensus Group on Protein did comment that people with kidney disease may not need such high levels, or the levels should be monitored. Saying that, as I said in the presentation, those highest levels of protein are really hard to achieve for somebody who's not got a good appetite. So I think as dietitians, you would need to consider that and use your judgment and expertise with your individual patients.
Next question. What do you think will be the challenges in care homes?
Alison, can you comment on that? Okay, I'll say something up. I'm not sure if I'm being heard. So as we've identified in this talk, it would seem care homes are where the most vulnerable patients are. So they're already full of people with frailty, multiple conditions, and potentially at risk of malnutrition or already malnourished. And these are the patients who seem to be catching COVID in high proportions and succumbing to it. It's really difficult. I'm not in practice, so I don't know how dietitians are managing care homes practically, but all the information we've provided in the talks tonight hopefully will help you start to think through some of the things you need to consider when supporting care homes, and presumably trying to identify who in the care home is most at risk of malnutrition will be one of the first steps, and assessing appetite, how appetite is being affected, and how you can help patients with a poor appetite to eat more of that nutrient-dense food that Alison commented on in her presentation.
Next question. Should we be advising extra vitamin D during this time for older people?
I think, as I said in my presentation, the recommended amount of vitamin D is 10 micrograms a day for all adults. I don't think, unless somebody has a diagnosed deficiency, it's sensible to give higher doses of vitamin D. There can be negative effects of mega doses of vitamin D. So a vitamin D deficiency does need to be identified and then monitored if you're giving very high doses. So the recommendation at the moment is to make sure everybody's having the daily amount, which is 10 micrograms.
What do you think will be the challenges in care homes?
You want me to take this one, Mary?
Yes, that'd be great, because I've answered a similar one just before. So you go, Alison.
Okay. Okay, hopefully we're not going to say completely different things then.
I think there's a lot of challenges in care homes. I think you have people with, a lot of people will have cognitive impairment, so their understanding of the situation in the world is going to be limited in some cases. There's going to be people who are quite scared, I would imagine, of the use of PPE where it is available. You're certainly going to have people who are missing their families because obviously people can't visit. We also know that the number of deaths in care homes where COVID is present seems to be quite high. So all of these are incredibly challenging times. It's also about things as simple as making sure that caterers can actually access the ingredients that are needed. We knew sort of at the beginning of the COVID crisis there were problems with being able to access the right ingredients, which obviously in itself is quite a challenge. So I think you've kind of got all of the things that everyone else is facing as challenges, and then you've also got the fact that staff are having to come into care homes to provide care. Some, I'm sure we've all seen on news, some carers are actually living at the care homes or camping outside the care homes just so they are reducing the risk of them bringing COVID into the care home. So there are lots and lots of different challenges, I think.
Next question. Do you know what is provided in shielded food packs? So just to reiterate what we mean by shielded food packs, these are emergency food parcels delivered free of charge to those identified as risk.
Yes, I do know approximately what's in them. They are slightly different depending on where you are in the country. They are quite limited in terms of what can actually go in the packs. As a dietitian, obviously, I was very keen. I've worked with my own local county council to help them to ensure that what's being provided is nutritionally complete as much as it can be, and I know that the British Dietetic Association has been doing quite a lot of work working with Public Health England and with DEFRA to really try and ensure that there is some dietetic input into this as well. I know that one of the comments that I've seen about these is the packs are very beige, so I'm aware that that is a concern from people. The challenge you have is that these obviously are packs of food that have to be mainly long life. They have to withstand being packed in a box and obviously basically travelling quite some distance. So much as they are not what we would necessarily envisage as being the best possible diet, they will at least provide people with the nutrition that they need for a relatively short period of time. If you look at the difference between what's in these food packs and what goes into food packs, sort of emergency food packs from food banks, they're actually very similar. So really that's where the evidence has come from. And to be honest, having seen some data that again was shared with me recently, looking at food bank parcels, actually, although to our eyes as dietitians, we might be thinking, oh, not brilliant, not much fresh food, not much fruit and vegetables other than tinned. Actually, the food packs actually met most people's nutritional needs. So they're not perfect by any means, but they will meet people's needs for a period of time.
Next question. Would it be worthwhile for the BDA to design a national audit tool for us to collect data on nutritional parameters?
I'm not entirely sure what you mean by a national audit tool. All I know is that the information about people who have had COVID-19 and have moved back into the community, so people who've been in hospital and moved back to the community, is extremely limited. And I don't think that is isolated to the UK. I think that's probably similar in other countries as well. And also in the UK, we know very little about COVID-19 in the community because we've only been testing people in hospitals. So we have very limited information about what is going on for patients in the community. And for that reason, it would be good to start to try and collect something. And my suggestion at the end of my slides was, I suppose, an appeal to dietitians in a position to try and build some data collection or evaluation into any processes they're developing to manage this situation, that could be really useful to the whole community and help us understand a bit more what the problems are and how patients respond after, in their recovery phase in the community. So I'd be really interested to hear from anybody who's got an idea of data they're able to collect, and your best way to contact me is via the BDA. So they'll receive your emails and forward them. So hopefully that answers your question and indicates what the BDA is trying to do in terms of coordinating efforts to collect some information.
I'd also suggest that if anybody has developed an audit tool, if you're prepared to, sharing it with the BDA, because an awful lot of the resources that I've talked about and that are on the BDA website, they are being developed by individual teams of dietitians around the country. But to save everybody reinventing the wheel, basically, if you're willing to share with the BDA, and then it's likely to be able to go onto the website, and then everybody else can benefit from it as well.
Next question. If you work in tertiary referral hospitals, how can you access all the local CCG pathways? Could a network help to provide support for all areas?
Ooh, that's an interesting question. I think the challenge is that different CCGs will have slightly different guidance. It very much depends on whether there are, in terms of being able to share this information, it depends whether there are prescribing support dietitians working as a part of the CCG, I would say. If there are prescribing support dietitians, it's highly likely that they will have tried to contact and tried to work with your organisation to share the information that's available. Sometimes there are barriers in both directions in the past. Hopefully those barriers are starting to break down quite significantly, which is great from that perspective. But if you have a clinical commissioning group that doesn't employ a prescribing support dietitian, it may be more difficult getting hold of that information. I think it is a case of trying to contact the organisation and asking what the guidance is about nutrition. And it's really a case of sort of finding out everywhere that you can and talking to sort of local dietitians. Usually dietitians in the community will have some idea, but to be honest, this is about saying you probably needed to know this beforehand. If you're only finding out about it now, then yes, great, fantastic, but it's keeping that knowledge for the future as well.
Next question. Can you expand more on advice for taste changes with COVID-19 patients?
Well, I reiterate really what I've been saying is we've got really very little information about this problem. Lots of people seem to be reporting that there are taste changes and smell, changes in smell, loss of smell, which obviously affects taste as well. But I haven't been able to find any sort of collective data on this from any country. So we just don't know. We just don't know how long it lasts. We don't know exactly how it manifests. We don't know how people respond to it, how they change their diet. There's lots of unanswered questions that would be useful to start to try and understand a bit better, because as we know, until there's a vaccine, this infection is going to be around, and people are going to continue to get it, albeit hopefully at a manageable rate, over the coming months. So that's something I'd be really interested to find out more about, is the appetite loss, changes in taste and smell, and how they manifest in people who are recovering in the community. So again, if anybody has any information, any ideas, or can help, please do contact the BDA.
I'd suggest perhaps one of the places, as a dietitian, the places to start is perhaps extrapolating from other places, other conditions where we know that taste changes are a problem, So if you're familiar with people when they've had certain cancers, certain treatments, that causes taste changes. Yes, it's a completely different situation, but it's possible that some of the things that might help then might help in this situation. Exactly as Mary says, we just don't know. So it's a case of try the things that sound like they might work.
Next question. Does curcumin improve inflammation in patients with COVID-19?
So curcumin is another name for turmeric, and there is no data to show any effect of this in the COVID-19 situation. And to be clear, there is nothing that you can take, no supplement that you can take that's going to strengthen, in inverted commas, your immune system to avoid this infection. There is some data about curcumin and immunity and inflammation, but there is nothing. There's nothing strong enough. There's not enough robust evidence to make any recommendations for any specific disease state.
Next question. I wondered about the relationship between activity and HMB. Some research I read suggested HMB had minimal benefit in those with poor blood flow, sedentary inactivity.
The data I've looked at with HMB, so the data I presented in my slides, showed that HMB had an effect on muscle mass. And if you look at individual studies, there's a variability in whatever outcomes it affects. There's also a lot of data in the sports performance side of things, which I'm not nearly as familiar with. And so the mechanism of how HMB works or doesn't have its effect, I'm not really sure. But what I do know is that in the frailty situation, any nutritional supplement, the research seems to show that there is a better response if it's combined with exercise. And so that might be the same with an HMB supplement. It's the person will respond better if it's combined with exercise. But that's speculation. I don't know, and I'm not sure that is clear in the literature. So I'm not sure anybody is really clear about that yet.
Last question. This is more for Alison. What are your thoughts on HCPs using coronavirus as a reason to increase the prescribing of ONS? Therapeutically, not necessarily clinically indicated. Do you feel prescribing support dietitians will have more ONS reviews in 6 to 12 months due to the lack of ONS reviews that were initiated during COVID?
Gosh, that's a very good question. Yes, I think it's highly likely that we will see greater use. On the other hand, we haven't had the patients in hospital who might have been discharged ordinarily with oral nutritional supplements prescribed. So it is one of those things that, again, and I apologise, we're both saying we just don't know to a lot of things because we just don't know. But it is possible that we won't see huge amounts more in terms of volume. I think we may see different products having been requested. I think the key thing, coming back to sort of what I said in my part of the presentation, is the review of these products is incredibly important. It isn't okay to just start an open-ended prescription and never review it, because to be honest, we have no idea that patients won't necessarily take things the way we think they will. So it is really important that there is some sort of review factored in, but it's also incredibly important that patients understand that food contains nutrition too. That the nutrition isn't just in these special products that are on prescription, that food contains it too. So the two things have to work together. And that once people start to regain their appetites, it may be a case that for a lot of people, you can actually wean down the prescribed products and improve the nutrition from food. So I think it is really important to see how we as dietitians, full stop, but certainly as prescribing support dietitians, how we can really work with our colleagues and work with other healthcare professionals too, to make sure that we're continuing to keep this messaging and we're continuing to talk about this in the months to come, because exactly as Mary said, this coronavirus is not going away anytime soon, so we're just going to keep on having to manage it and having to manage the outcomes from it. So it's a case of basically thinking quite practically about how do we manage this, because people are still going to need nutrition support in the future, and it can't all come from prescribed products.
Thank you very much to Mary Hickson and Alison Smith. It's been a great presentation this evening. We have now come to the end of the webinar. Certificates will be available. They'll be on the webinar link, and there will also be a reflection tool sheet for healthcare professionals to complete. So the recording of this webinar will be made available on the BDA website and the Nestlé Health Sciences N+ Educational Hub. Thank you very much for joining.